that fishery subsector have an average of 5% of GDP. There are a lot of need in fishery in our countries. So fishing community, we have a lot of, we have 300,000 fishermen and fishermongers along this corridor. And these populations are highly vulnerable to HIV. And we noticed that there is an absence of projects specifically target fishermen. And also, we have lack of data to assess the extent of the AIDS epidemic among fishermen. So for us, there is a necessity and opportunity for ALCO to do this IBBSS in order to have data, and those data will permit us maybe to draft a project and implement this project for this target population. So the main objective of this study is to contribute to a better knowledge of the situation of HIV epidemic among fishermen along the Abidjan-Lagos corridor organization. So having said that, we're going to see the results of this study. And let's say a total of 4,426 people were surveyed along this corridor. And in Côte d'Ivoire, we have 559. In Ghana, 2,172. In Togo, 594. And in Benin, 590. According to the distribution of respondents, according to the sexual activities, type of partner, and sexual practices, we noticed that the age of at the first intercourse is the same within the 5 countries. And this age is between 15 and 19 years old. So you can see the percentage on the screen, the percentage for each country. According to the condom used at the last sexual intercourse by type of partners, the majority of respondents did not use a condom during the last intercourse, regardless of the type of partner, and in particular, we partner at more at risk of HIV. For example, if we take Ghana, only 31.5% use a condom at their last intercourse with a business partner. And this data is 62.5 for the Benin. So you can easily see with me that the majority of respondents did not use condom. And this is a real problem along this corridor. I'm talking about fishermen. So according to the exposure to information on family planning, knowledge and use of structure offering family planning services, the main reason for not having access to structure offering family planning services is that the respondents say the distance is too long to go to the structure offering this kind of services. So 27.7 even here of family planning along this target population. You can see only 27.7. And for the the services, the frequency of attendance or at structure offering family planning services in the last month, we just have 17.7% of the whole respondent of this study. So you can see that, for example, in Nigeria, we have only 12.5, in Côte d'Ivoire, only 12.3. So most of the respondents, they don't have attendance at the structure offering family planning services. According to the distribution of respondents, according to whether they have a good knowledge of HIV, we noticed that regardless of the country and gender of the respondent, a small proportion of respondents have a good knowledge of HIV. And you can see that in Côte d'Ivoire, only 28.7% have accurate knowledge and rejection of misconception. In Ghana, only 14.7%. In Togo, 30.3%. And in Benin, 11.6%. So you can see that globally, the behavioral indicators are not good at all. Whatever the country, the proportion of correspondents who have a tolerance to people living with HIV is higher among respondents with a higher level of education. So you can see that for those who have secondary or who have was in the university, they have good tolerance according to the person living with HIV. So basically, we can say that when they are instructed, they can understand stigmatization, and then since they understand, they can know how to deal with the person living with HIV. For the exposure to action to prevent STI, HIV, and AIDS, less than 10% of respondents, regardless of country and gender, report having received a combination package of HIV prevention intervention in the past 3 months. So when we go through the country, you can see that 6.3% of the respondents of this study receive a combination of package of HIV prevention intervention in the last 3 months. And for the other country, namely for Ghana, for example, is 2.2, Togo 7.3, Benin 0.8, and Nigeria is 2.5. And also in this screen, we can see that less than 50% of respondents even receive free condoms. So, during most of our activity, we need to distribute condom. The National AIDS Control Program, they used to distribute free condom. And you can see that they don't use to benefit from this free condom. So that means that our activities at the national level did not reach this target population. For the access to HIV testing, ART, and viral load by country, also regardless of country of residence or gender, The reason for not using HIV screening, prevention, and treatment services for a large majority of respondents is fear of being stigmatized by health staff or neighbor. You can see that for these indicators is very, very important because with regard to that, we know which intervention we can do and which people we can target to make sure that stigmatization we can reduce stigmatization among this target population. And finally, for the HIV prevalence, you know that when we are talking about IBBSS, we are waiting for the result of the prevalence. The average HIV prevalence in the 5 countries is 2.7%. And the country with the highest prevalence is Benin. It is my country. And the lowest prevalence is observed in Nigeria with 1.6%. So you can see that this prevalence is higher than the average at the national level for people aged between 15 and 49 years. And you can see that the higher prevalence is in Benin, followed by Cote d'Ivoire, Togo, Ghana, and the last, Nigeria. Also, this screen shows the HIV prevalence in fishing communities and you can see the prevalence within the woman, the man, and the total one. And as we all know, in most of the country, the prevalence is higher with the woman than the man. In this screen, you can see the HIV prevalence in fishing community by country and by site. So we have the HIV prevalence in each site, and based on that, we can know exactly where the prevalence is higher, where we need to do HIV prevention activity to be sure that we can reduce the prevalence of HIV. So we have the prevalence globally, but we also have this prevalence in each site. So you can see that, for example, in Grand Lao in Côte d'Ivoire, the prevalence is 4.3%, when the average prevalence at the national level is lower than this. So we know that if we want to do activities in Côte d'Ivoire, we have to target this Grand Lao. Also, you can see that Grand Bassam, the prevalence is 4.3. So we need to also target Grand Bassam. And if I take the example of Benin, we can see that in Grand Popo, the prevalence is 6.9%. You can see that this prevalence is higher than the average of national population when we consider that this prevalence is 1.1 in Benin. And also, apart from Grand Popo, even in Cotonou, you can see that the prevalence among the fishermen is 3.8. In Semepoji, this prevalence is also 5.6. So we have a lot of to do along this corridor to reduce the prevalence among fishing communities. This screen is to compare the HIV prevalence in fishing communities and among adults aged 15 till 49 by country. So you can see that in all the 5 countries, the prevalence among fishermen is higher than the average at the national level. You can see, I was telling for Benin that the prevalence is 1.1%, but I think that the last study they did, the prevalence within this age is 0.9 compared to 4.6 with the fishing community. You can see that it is like a key population. We have to target them. We have to do activities to target this population if we want to reduce the HIV prevalence in the country. Also, for Cote d'Ivoire, you can see that the prevalence among the fishermen is 3.4 compared to 2.1 among adults aged 15 till 49 age. Finally, the result of this study confirmed the specific vulnerability of fishermen, highlighting the need for countries to pay regular attention to this population. They will serve as the basis for confirming, strengthening, or reorienting the intervention depending on the case. The analysis of the results show that most of the behavioral surveillance indicators are not brilliant. Exposure to the risk of HIV infection among fishermen is a big concern and requires planning and strengthening targeted intervention to be to the benefit of this subpopulation under study. Also, HIV prevalence among fishermen in all 5 countries is relatively higher than the national average in the general population among adults aged 15 to 49. Having said that, we suggest an outline of a project that we can implement along this corridor to reduce the HIV prevalence. And we can say that we need to raise awareness on STI, HIV and AIDS through local station radio. According to the health and HIV, we need to do outreach strategy to target fishing community for HIV testing, treatment for HIV positive people, and we also need to implement a differentiated minimum package of activities for HIV prevention and sexual reproductive health for fishermen and monitor it. We also need to strengthen biological and behavioral monitoring of fishermen. We at ALCO level, we did the first study, but when we will when we will implement activity to target this population, we have to monitor it. So we have to do regularly a kind of IBBSS. We also propose that we give support for organization by creating a sub-regional network of fishermen that will permit us to discuss along the Abidjan-Lagos corridor. We also have a human rights and gender part in this program. We need to do the regulation, the labor law, talk about gender, since we know that within this target population, they don't respect the labor law. And finally, we need to build the capacity of health center close to the fishing site to make sure that when fishermen would like to have a care, they can benefit from a care in a health center who is well built. Thank you for your attention. I want to thank the Society for Health in Africa, especially his director, Mr. Luc Amambodea, who permit us to be here today to do this presentation. I also want to recognize in this room the delegation of Benin, led by Dr. Kiki Mendega. Thank you for your support. Thank you also for the National Health Control Program of all the 5 countries. Over to you. Thank you.
Thank you very much, Dr. Abdel Aziz. I will ask Kosi to make a short summary of the presentation in French, very short.
Je vais donc essayer de faire une petite synthèse sur ce que nous avons suivi tous ensemble, en remerciant le présentateur. Donc, c'est le résultat d'une enquête menée sur 4426 pêcheurs recrutés tout au long du corridor Abidjan-Lagos, donc en passant par la Côte d'Ivoire, le Ghana, le Togo, le Bénin et le Nigeria. Ce sont des jeunes gens âgés de 15 à 19 ans, donc des adolescents en grande majorité, qui ont été recrutés dans cette enquête. Et en matière de comportement à risque d'infection sexuellement transmissible, donc à risque de VIH, nous avons vu que seulement 31% à 62% ont pu utiliser le préservatif lors du dernier rapport sexuel avec un partenaire sexuel occasionnel. Ils ont un accès très limité au service de planning familial à cause de la distance qui les sépare de l'accès aux structures dispensatrices de ces services. Ils ont une mauvaise connaissance en global de l'infection à VIH, donc moins de 20% ont une connaissance bonne de l'infection à VIH, ce qui se justifie par le fait que seulement 0,8 à 7% seulement ont bénéficié les 3 derniers mois d'un paquet complet d'interventions en matière de prévention de l'infection à VIH. En ce qui concerne la prévalence, on note une prévalence moyenne sur une prévalence moyenne régionale de 2,7%. On note quand même que dans cette population spécifique, elle était de 1,6% à 4,6% chez les pêcheurs. Et les villes qui doivent retenir quand même l'attention, curiosité étant, c'est Grand Bassam, Grand Popo et Grand Laou, comme si les villes commençant par Grand offraient une particularité par rapport à l'exposition à l'infection au VIH, avec des prévalences qui vont de 2 à 5 fois la prévalence nationale dans ces pays, ce qui fait de cette population une population particulièrement à risque. Le communicateur a donc fait des recommandations sur la nécessité de renforcer la promotion de la santé en global par rapport à cette population spécifique, en sensibilisant davantage sur l'infection à VIH, offrir le service de dépistage, de traitement, dans une approche différenciée de soins. Voilà, mesdames et messieurs, ce que nous avons suivi, et la parole sera à vous pour d'éventuels commentaires. Je vous remercie.
Merci beaucoup, Kosi, pour le synthèse. Colleagues, we will close this session at 4 o'clock. That means we have about 15 minutes for questions and answers. Please, you can raise your hand when you are given the mic, introduce yourself, and then make your comment or ask your question. The floor is now open. Who's helping us with the roving mic? Yeah. Okay, there's one there. There's one there. Any other hands, please? There's a second one there. Any other more? We can take about 2 or 3 questions, and then we can ask the presenter and his colleague to respond. So we have the first question. Please introduce yourself and ask your question.
Merci, je m'appelle Capin, je suis du programme SIDA en RDC. Je suis un peu curieux par rapport à la population féminine qui est dans l'étude. Est-ce que cette population féminine fait la pêche ou bien c'est une communauté qui accompagne les pêcheurs? Parce qu'il me semble que le taux de prévalence avait l'air plus élevé dans cette population. Merci.
Thank you very much to our colleague from DRC. Essentially, is concerned about the HIV prevalence among the females. So he wants to know whether they're actually fishermen or they are colleagues, I mean, their neighbors to the fishermen. That's the way I understood it. Can we have the second question, please?
Thanks so much. I'm Kevin Baragas from Malawi. My question was just on the distance from the, how close are the health facilities perhaps to the fishing communities? Just wanting to get a context of, the situation in the area where the study was implemented. But again, the other one was on what could be the driving factors for the high prevalence among females. And perhaps if you can just give more context as regards the setup in these communities. Is it that maybe there's a lot of polygamy or what? So just wanting to understand those things. Thanks.
Thank you very much. Any other hands up? Okay, we'll ask the presenter to respond to those two questions, and then we'll come back.
Okay, thank you very much for your question. Pour le collègue de la RDC, comme vous parlez français, je réponds en français, comme ça, ce sera plus simple pour vous. Peut-être que je vais faire une petite synthèse pour les anglophones qui sont là. Vous avez demandé, en fait, c'est quoi la population féminine? En fait, dans la population de pêche, nous avons aussi bien les pêcheurs que les mareyeuses. Les mareyeuses, c'est ceux qui travaillent avec les pêcheurs et qui aident à vendre le poisson. Et il y a aussi des pêcheuses. Il n'est pas rare de voir des femmes qui vont en mer avec leurs conjoints. Mais ce n'est pas la plus importante population. Dans cette étude, nous avons pris en compte aussi bien les pêcheurs que les mareyeuses. Donc, les mareyeuses, là, c'est celles qui travaillent avec les pêcheurs. So he wanted to understand why we have women among fishermen. So we have fishermen and fishermongers. You know, the women who used to work with the fishermen, they used to sell fish. Sometimes they also used to go on the field with the neighbors' men to do the fishing activities. So this study targets all this population. What is the distance between the health center and the community? It depends on the countries. So, you know, we have a lot of fishing communities along the Abidjan corridor. And when talking about health center, it depends on the site. If we take, for example, the site of Lomé, you know, Lomé, there is a port where fishermen used to do their activities. At that point, for example, we can have a health center, let's say, 500 meters, because at the port level, we have a health center. But when we take, for example, Grand Popo, you can see that the health center is not close to the fishing community. They have to do a lot of kilometers before they reach the health center. So, as you say, it can be a reason for why that target population they don't have access to healthcare services. So that's why we are asking for, let's say, to draft a kind of project to target this population. And within this project, we can make sure that they have health center near their communities and they can have access easily to those health centers. Thank you.
Thank you very much. Any other questions? I see no immediate hand. Oh, there's a hand there. Yeah, can we give the mic to the lady in front there, please?
Thank you. I'm Joyce Adim from Zimbabwe. I just wanted to ask, from the 5 countries in the study, was there or is there any intervention being done for the fisheries or the fishermen and women there? Is there any intervention that was or is being done along the corridors?
Yeah, thank you very much. No, tu peux répondre, elle peut ajouter, tu peux répondre.